All right, so my section, I'll be discussing multiple myeloma and non-malignant hematology. How is the voice quality, Joel?
It's good.
Okay, perfect. So I'll stay on the phone then. All right, next slide. Okay, so these are some of the key studies I'm going to ask. So obviously, we try to select studies which will have a cutting-edge impact on the way you practice today or in the next year or two, whether it's from a efficacy improvement, toxicity reduction, or a patient logistics standpoint. So there were not a whole lot of trials at the ASH meeting this year which met that threshold, but I'll show you a couple of the trials in myeloma which may have some meaningful reasoning for you guys to look at. The first question is, does the addition of the CD38 monoclonal antibody isatuximab to RVD improve outcome of care in patients with newly diagnosed stem cell eligible multiple myeloma patients? Next. Next slide. All right, so currently the FDA approval of Sarclisa, or sorry, can you go back to the last one? Okay, the current approval of Sarclisa is in combination with pomalidomide and dexamethasone in people who have received 2 prior lines of therapy. And also recently, March 2021, last year, isatuximab with Kyprolis and dexamethasone, who again received 1 to 3 prior lines of therapy. Next. So this is the GMMG HD7 trial, looking at patients between less than the age of 70, eligible for a stem cell transplant. They use the standard arm of RVD for 3 to 6 cycles as compared to RVD plus isatuximab. And then followed by that, stem cell transplant with high-dose chemotherapy. And then use the maintenance regimen using the standard lenalidomide, 10 to 15 milligrams, as compared to isatuximab plus Revlimid in 4-week cycles for up to 3 years of progression of disease. Now, some of you might argue that using a proteasomal inhibitor may also be considered a standard of care in this subset of patients. Next. All right, so these are the baseline characteristics. Overall, fairly well matched, age of about 60, good performance status patients, mostly with IgG type of myeloma. About 6% of patients on the trial had some kind of renal impairment. Stage 1 of about 37%, stage 2 of about 38, stage 3 of 24. As you can see in the elevated LDH, which is a poor prognostic factor, there were slightly more number of patients in the isatuximab arm. And also when you looked at the RISS, slightly worse prognosis patients in the isatuximab arm. Next. So this is the primary endpoint. So they looked at MRD negativity as one of the primary endpoints here. Looking at the experimental arm, adding isatuximab did increase the MRD from 35% to 50%. That was clinically significant with a p-value of 0.001. Next. These are some of the subgroup analysis, looking to see if there's a major difference between the 2 arms. Nothing which stands out here from a major treatment change perspective. So we'll go on to the next. These are the response rates. The isatuximab arm, complete response of 24 versus 21. So while the MRD was increased significantly, the CR rates did not seem to change. Near complete response of 41 versus 36. When you look at the very good partial response, that indeed did increase from 60% to 77%, p-value of less than 0.01. Partial response also increased, overall partial response of 83% to 90%. So across all the parameters, some improvement in partial response, and the very good partial responses. Next. Here's the safety data to see if there are any safety signals when you combine these. When we combine this agent in combination with the Revlimid-based regimens in the second line, we do not see a huge amount of increased safety signals. And similarly here in the front line, when you look at it, the biggest safety signals which have emerged in the frontline setting is some amount of increased myelosuppression. The leukocytopenia and the neutropenia increased from 9% to 26%. We've seen this in the second line trials also. The rest of the side effects seem fairly matched to to both the limbs. Next. Now looking at the dose intensity, if adding this medication will reduce the dose intensity of the current regimen and somehow impair the efficacy. So when you look at the dose intensity, the addition of isatuximab did not impact the dose intensity of the RVD baseline regimen that we have, and a small number of dose reductions, but it was not clinically significant. Next. So what we can summarize so far from the data that we have is that adding isatuximab to RVD does result in better rates of MRD negativity versus treatment with RVD alone. MRD negativity increased from 35% to 50%, did not impact the safety profile or dose density of RVD. So the trial is ongoing, and we do not have data about survival and such, which will come following the second randomization for the maintenance. Obviously, there are other trials looking at daratumumab in a similar setting where we're starting to get some preliminary data. But overall, I think this is a study which has shown that it is safe to use, may increase the MRD negativity rate. I don't know why it did not impact the complete response rate when it had an impact on the MRD. You would think that the CR rate would have increased, but we did not see that in the trial. So we're still looking at that analysis, which hopefully will be forthcoming in the next meeting or two. Next. So what we can say for now is that addition is safe and can be considered as one of the options that we have. I don't know that this makes a huge impact in the way you practice today. I mean, both the agents look very effective, isatuximab as well as daratumumab. Obviously, Dara has been on the market longer. They do have a subcutaneous version, which makes it easier if you have a chemotherapy chair shortage, because that can be given faster with maybe less infusion reactions. They also have the first-to-class effect, which is helpful for them for a marketing standpoint. I've not seen any differences in pricing or any contracting between the two drugs for us to make one way or the other a financial decision, but overall, I think that might be coming at some point. So I'm going to stop here on this one and ask Eric if this has any impact on his care of multiple myeloma patients.
You know, I don't think it does. It's not the standard regimen I would do before transplant. You know, to me, I've been using more Dara just for more the logistical reasons that you stated. You know, we have chair shortages, we have nurse shortages, so giving a sub-Q injection to me is beneficial. And in order for me to really change my standard of treatment paradigm, I'd want to see, you know, OS changes or something else. And again, the data is just not there yet for it at all. So while I have used ISA before in kind of refractory patients, I don't think I would use it in this setting.
Are you using any 4-drug regimen in the pre-transplant population, or are you sticking with the 3 drugs for now?
You know, it was interesting. You know, they have looked at data, they looked at the 4-drug versus 3-drug in the transplant setting. And you would think that the higher risk patients would benefit from 4 drugs, but it really didn't benefit too much. I do 4 drugs in my younger patients. Anytime you add a 4th drug to the cocktail, there's always toxicities you have to worry about. And I always tell my patients that this is a marathon, not a sprint. And so we have to be mindful of the cumulative toxicities these patients will experience over time. So I still do 3 drugs predominantly, but there are my 40-year-olds, 50-year-olds that do have myeloma. I'll probably do the 4th drug just to try to give them an MRD so they can have a great transplant and have a better PFS. But right now there's no OS that I'm aware of, so that's what I tend to do. And
I have a similar pattern, I think, as yours, Eric, and even the transplanters here have similar things. So the biggest take for me from this trial was that adding isatuximab does not compromise my delivery of Revlimid and Velcade, because we've already seen response rates hitting higher than 90% with these regimens. So it's not that I can achieve a whole lot more in terms of response rates. And like you rightly said, we may be able to increase the MRD negativity. And how much of an impact does that have when the patient's eventually going to go for a stem cell transplant anyway? I think only time will tell. So making sure that I can give the most effective regimen safely and not compromise what I'm already doing is still my primary goal. So I agree with your thoughts there. All right, next slide. All right, so the next trial I'm going to present is the Griffin trial, again, a multiple myeloma trial. Next. So here the question which was asked was, does the addition of daratumumab to RVD followed by dara-AR maintenance improve outcome for patients with newly diagnosed stem cell transplant patient eligible patients? So this will answer some of the questions which were asked already. Next. So this is an updated analysis of the trial which has previously been presented. Again, patients less than the age of 70 eligible for a stem cell transplant received a standard induction of RVD for 4 cycles versus daratumumab plus RVD, followed by consolidation, high-dose chemotherapy, followed by stem cell transplant, followed by consolidation of cycles 5 and 6 after the transplant with daratumumab RVD versus RVD, and then a maintenance regimen of daratumumab, Revlimid versus Revlimid alone. Next. And again, the baseline characteristics are fairly well matched. Age less than 70, performance status 90% of the patients with PS 0 or 1, kidney impairment in about 10% of the patients, high risk staging. When you look at the ISS staging, 47% stage 1, 38% stage 2. Cytogenetic profile did include the high risk patients, deletion 7p of about 8%, translocations of 414 or 416 of about 10%. Next. And these are the response rates that we saw. Complete response improved at the 2-year maintenance. When you look at the updated data with the daratumumab RVD arm is now at 66% as compared to 47 with the RVD, CR of additional 16%. And you can see the trial is ongoing, so some improvement as time is going along, and the p-value is still holding up at a 0.009 at a median follow-up of 3 years. Next. These are the MRD status. Again, MRD, when you look at the 10 to the power of -5 threshold, 64% with the dara arm as compared to 30% with the standard arm of Revlimid, highly clinically significant 0.0001, more than or equal to CR of 78% versus 47%. MRD, when you look at a more sensitive test with the 10 to the power of -6 threshold, 36% versus 15%, more than or equal to CR in those subset, again, 43% versus 22%. So certainly seeing the MRD negativity sustaining over time is definitely helpful, and hopefully will be predictive eventually of bigger and bigger improvements in overall survival with this anti-CD38 class of drugs. And then down in the bottom, you see the data based on the revised cytogenetic risk. So for the high-risk patients, 32% versus 54, and the standard risk, 31 versus 75. These are the patients with the relapse. Next. So these are the very relevant PFS and overall survival improvement. So we can make a difference in the molecular levels, but can we impact of how we actually treat the patient and how the patient feels? So when you look at the PFS at 24 months versus 36 months, the 24-month data was presented previously. Now we're at 36 months. PFS is now at 89% versus 81%, hazard ratio of 0.41. It does cross, the confidence interval does cross the 1.00 threshold, but it's getting better over time. So the hazard ratio is 0.46 with the confidence intervals of 0.21 to 1.01. And the study was not powered for PFS analysis, so I don't know if this will eventually land up being clinically significant, but at least statistically or numerically, it is looking like the curves are splitting apart as time is going on. Looking at the overall survival, 24 months was 94% versus 93.3%. Now at 36 months, again, there's not much splitting of the curve, 92 versus 92.6 versus 92.2. So really, numerically, the overall survival is not split up at 3 years at this point. And the median numbers were not reached in both arms, which tells us that we're still doing fairly well with this subset of patients. And then there is some PFS benefit due to separation of curves, but we'll see how time goes along and see if this PFS improvement will eventually translate into an overall survival improvement. Next. These are the side effect profiles. Again, looking to see if we use this during the maintenance therapy, is there any worsening of the worsening of the side effect profile? So infections during the maintenance setting, 18 versus 21%, did not seem to be different. Very similarly matched between the two arms. Type of the secondary malignancies, again, small number of patients, mostly skin cancer. We're starting to be very prudent about this on patients who are on Revlimid maintenance. The incidence of skin cancers is increased, and most of our patients we do send for a dermatologist visit every year at least, if not more, if there are any suspicious lesions. Again, something we have to keep a close eye on for this, as well as the colon polyps and a small risk of uterine cancer. Next. So from what we can summarize from this is that it does improve the complete response and the MRD negativity. 24 months, you can see the data is 66% versus 47. There seems to be a trend in the PFS. Overall survival has really not changed, and the safety profile seems to be maintained after one more year of follow-up on the data that we have seen. Next. All right, so we'll await more data, which will hopefully be presented at the next ASCO or ASH meeting. Next. All right, next. So the third trial, which I think was something that we're all eagerly awaiting for with the use of venetoclax now in several cancers, is the role of venetoclax in relapsed refractory multiple myeloma. We have heard a lot about the side effects. We heard about its activity in BCL altered patients and such. So this trial, the Bellini clinical trial, asked the question, does the addition of venetoclax to bortezomib and dexamethasone improve the outcome for patients with relapsed refractory multiple myeloma patients, since this is a very challenging subset of patients to treat with the risk of infections and such. Next. So here's the study design. Key eligibility as patients with relapsed refractory multiple myeloma, anywhere from 1 to 3 prior lines of therapy, not refractory to proteasomal inhibitor therapy. That's the key here. The arms which are used in this study was a 2-to-1 randomization using venetoclax with a dose escalation up to 800 milligrams daily, and Velcade and dexamethasone in standard arms given subcutaneously. So the bortezomib on the cycle 1 to 8 was given day 1, 4, 8, 11. Not sure how many of you are using this regimen versus using the standard weekly regimen. And after cycle number 5, they received the standard weekly regimen of bortezomib day 1, 8, 15, and 22. Eric, what's your practice in your practice? Do you guys use the 4 doses every 3 weeks of bortezomib, or do you do the standard sub-Q once a week? What's been your practice?
We do this weekly sub-Q once a week. You know, we do 1, 8, 15, 22. You know, initially when it came out, insurance made us do 1, 4, 8, 11, but the last 4 or 5 years we've been able to just do the weekly doses.
And we use the same thing, except I think in our patients with renal compromise where we need them to respond quickly, then I've used the twice a week regimen, but otherwise with the risk of neuropathy and this like you said before, this not being a run to the finish line, we do want to reduce the risk of neuropathy in these patients. So that's probably what we've used also. All right, next. All right, so these are the baseline characteristics. We have about 3-year survival data, 3-year follow-up data on this. Median age of about 65, stage 1, stage 2, and stage 3, as you can see, of about 40%, 35%, and 20%. Half of them had performance status of 0. So I think a highly selected subgroup of patients, and the other half of a PS of 1 or 2. Prior exposure to proteasomal inhibitors of about 70%. Prior exposure to IMiDs of about 70%. And then you had the cytogenetics there, standard risk of about 73%. And then the two most important questions on the bottom side, how many patients had the translocation, 11, 14. So that's about 10% of the patients or 15%. And a BCL2 expression high being about a third of the patients on the trial. Next. So these are the PFS and overall survival benefit jumping straight to the efficacy data. So when you look at all patients, the venetoclax arm had a PFS of 23 months as compared to 11 months, highly statistically significant of 0.0003. When you look at the patients with the translocation, small number of patients, went from 9 months to 36 months. Again, statistically very significant. Patients with the BCL2 went up from 9.9 months to 30 months, again a tripling, p-value of 0.0005. And when you look at the median overall survival, this has still not been reached, which is very promising, especially in this highly refractory population. We'll hopefully see some data, and we already reached a median follow-up of 45 months. This just tells us how much we have improved in multiple myeloma when we have third-line patients who are having a median follow-up of 45 months, and we have still not reached the median overall survival. I mean, it just looks like the other day when I started my fellowship training, when our average survival for frontline patients used to be 4 years or so. So this is quite promising as to the wealth of therapies that have been approved in multiple myeloma and how we have changed treatment in this disease. Next. So these are looking at the response rates, overall response rates in the overall population of 84% versus 70%. Increased significantly in that small number of patients with a translocation 11-14 doubled from 47 to 95%. In the BCL2 patients, 75% versus 88%. And when you look at the MRD data, this is a story which is evolving with the BCL2 inhibitors in every disease. We seem to see a bigger response. We've seen this in CLL, and I think Eric will be discussing this in the panel discussion at some point. As you can see, the MRD numbers, and remember, these are not frontline patients. These are fairly advanced patients. We're seeing MRD negativity in a significant number of patients with the addition of this medication to the proteasomal arm. And we know that, as you can see on the other arm here, proteasomal inhibitors by themselves do not induce a huge amount of MRD negativity in the second and third line. They do that in the front line. Next. All right, so these are the safety one. This is something we've all been waiting for to see because we've heard about side effects with this agent when you used it in the second and third line. So I'm going to go with the first part here so we can spend some time on this. GI side effects, 60% versus 50%, so slight increase in GI diarrhea. Fatigue, constipation looks very similar. There's some increase in nausea, which can be managed with oral anti-nausea medications. Peripheral neuropathy numbers look very similar. Upper respiratory infection, overall grades look very similar. And then in the bottom part on the left, you'll see the common hematological adverse events. Thrombocytopenia, again, slightly different. Neutropenia, slightly increased. And on the right side, when you look at the infections here, that's, I think, the key data that all of us have been waiting for. Overall, all risk of infection, 82% versus 78%, not that much different. The grade 3 and 4 infections, on the other hand, did increase from 29% to 41%. So certainly something to pay close attention to, because this is what we had seen initially in the phase 1 trial, was an increased risk of grade 3 and 4 infections. So pay close attention to the neutropenia risks and such, and be careful about watching out for infection here. On the bottom here is the total number of deaths, all deaths, 40% versus 38%. Treatment emergent deaths, 7% versus 2%. Most of these are caused by infection. As you can see, infection of 5% in the venetoclax arm and 0% infection-related death in the standard arm. Next. So in summary, treatment with adding venetoclax in combination with bortezomib and dexamethasone significantly improved the PFS in this highly, hard to treat population of relapsed refractory multiple myeloma. The largest PFS improvement was seen in patients with the translocation 1114 or high BCL2 expression. It did result in more amount of frequent and deeper responses compared to the placebo, especially in the subset of patients with the translocation 1114 or the high BCL2. And there was a trend towards improved OS, which will hopefully see more data in the next meeting or two. And then finally, from a toxicity standpoint, obviously pay more closer attention to the infection risk when you add venetoclax. Next. Next. All right. So we presented all these data on the malignant hematology. So we had to present at least one case on a non-malignant hematology. So we decided to proceed with an update presentation on fostamatinib in ITP. Next. So this is the current FDA approval for Tavalisse or fostamatinib, which is a kinase inhibitor indicated for the treatment of ITP, who have not had a sufficient response to a previous treatment. Next. So these are the improvements that we have seen with the long-term use of fostamatinib. About 70% of patients who go on the drug demonstrate a sustained clinical benefit over time, as defined by a platelet count of more than 30,000. And out of those, 26% have a were initially not classified as the overall responders because the threshold was 50,000. So you may have seen this on the package insert. So this is the revised numbering based on, so the 44% that you see in light blue are patients who have had platelet counts of more than 50,000. And the one in darker blue, which is the 26%, are the patients where the platelet improved to more than 30,000. And a third of the patients had no benefit with the use of this medication. Next. So this is looking at the median platelet counts over time. These are combined results from the FIT1, FIT2, and the FIT3 trial. As you can see, the median time to first response is about 2 weeks, and the overall response we talked about, and the clinical benefit. And a lot of these do tend to be sustained over time. Next. Okay. So as you can see, the response to fostamatinib was seen in patients across all lines of therapy. And as you can expect, as you use it in later lines, the response rates do drop. So if you use it in the second line, 94%, third line, 86%, and the fourth line is about 59%, and across the board, a clinical benefit response rate of about 70%. Next. So these are the safety analysis. The biggest safety with this medication is the diarrhea risk. So about 36% of patients developed diarrhea, 2% of it was severe, some increase in hypertension. Otherwise, as you can see, the severe side effects are very minimal, fatigue and headache in one patient. One of the things we've seen with ITP is that it is a prothrombotic state, even though the platelet count is lower. There is a risk of about 3 to 6% risk of thrombosis, especially when the platelets overshoot the number of 150, 200,000, which is why we are careful with the TPO receptor agonist not to overshoot that number. There is an increased risk of thrombosis. We've not seen a whole lot of thrombosis signal with this medication in long term. So that's the one thing which is different between this and the TPO receptor agonist. Next. So in summary, it's an oral spleen tyrosine kinase inhibitor, different mechanism of action. It does target the underlying autoimmune cause of ITP by blocking platelet destruction. So 5-year safety analysis kind of holds out the initial data that we have seen. There are some trials now looking at it second line. Next slide. And also this one other trial I'm very interested in is the trial in warm antibody autoimmune hemolytic anemia, where our treatment options are limited. So they're showing some data there. So hopefully we'll see some efficacy data soon. So that's kind of where we are with these drugs.